The DSM-2 came out in 1968, but notice the 60s, the flower children, it was basically the age of humanism was starting, and so it was similar. They got rid of the term reaction. Thomas Szasz, that we talked about, was starting to look at this mythic thinking that was associated with mental illness, that I will tell you is still there. I would suggest to you that it's gotten better, but people still see hypnosis mythically. That's why the pre-induction work we do is so powerful, because we have to break through the barrier of mythic thinking to help people to be open to see that they can create change for themselves with hypnosis, that we're helping them to access their own resources, and we're doing it in a way that is respectful to the whole person. The DSM-2 also went through some tension points, and the reason was because they had considered back then that LGBT issues were part of a medical illness. It was a disorder. And so it was a time where it was starting to be challenged and confronted. By the 80s, the DSM-3 came through, and this was a revolution in psychiatry because they were starting to also look at a better conceptualization of blending science with the diagnoses and helping to understand a little more about, well, how do we help people? It still had its limitations. By the time we got to the DSM-4, which is in the 90s, this was a huge shift. They basically came out with what we called a multi-axis system. So you had axis 1, which had to do with what is your diagnosis. Basically, is it depression? Are you dealing with anxiety? Are you dealing with psychosis? Axis 2 was personality disorders. And also what used to be called mental retardation was actually axis 2. We now have gotten rid of mental retardation. The reason is because it became so pejorative that it was a pejorative term. I remember growing up and being, on the playground, you retard, in other words, I think we'll probably take any of the terms that we have and they will become weaponized, and then they'll have to be changed. We now use the term intellectual disability to refer to some cognitive dysfunction, a cognitive deficit that is more neurodevelopmental. With the axis 3, in the DSM-4 is they would say something about what medically are you dealing with. Axis 4, they looked at what are the quote-unquote psychosocial stressors, what is impacting on your life. And there was a point system and also to look at, to what extent, is it mild, moderate, severe. And then the last one was called a global adaptive composite, or a global functioning index. And what it did is it assigned a number from like 1 to 100. And of course, the lower the number meant that you had less impact from all this. And as it got up toward 80, 90, 100, that could be so severe that you weren't functional. When I would use this system back in the 90s, typically outpatient work was roughly, let me reverse that. The lower numbers were for more dysfunction. The higher numbers were for higher functioning. So what that meant is outpatient work, roughly the lowest you'd see would be maybe 50, 60, 70. And then as you got into inpatient work, the numbers would be 40. And if you were in a residential center or a psychiatric hospital, you might be in 20 or 30. As we got to 2000, they made modifications in the DSM-4. They called it the TR. The DSM-5. And basically, it took the DSM-4 TR, which was another modification in that multi-axis system. And in the DSM-5, they made changes. They got rid of that axle thing. So basically, they also moved toward considering diagnoses as being on a spectrum. You may have heard like autism. Now it's called autism spectrum disorder. OCD would be like OCD spectrum disorder. In other words, the diagnoses from before tended to pigeonhole people into little boxes. And this says, wow, there's a range of how you might experience this particular diagnosis. And that's the purpose. That's a big conceptual shift. And then they also wanted the whole meaning of a diagnosis is that it has to have clinical utility. It has to have usefulness. You just don't assign it to assign it. And it has to have some meaning so that it creates a path toward helping somebody. That's huge. So we're getting into conceptual shifts. Now, is there still a need for more conceptual framework and making it more applicable into everyday diagnostic work? Yes, but this is huge with the shift. There also was a blending of neuroscience, sociological issues, importance of, this is powerful, the importance of culture. For example, in some cultures, if at a funeral, people might be just wailing and crying and draping themselves over a casket, and it could be, if you walked in and saw the level of just pain and discomfort, it's visceral, and with that, you could also, in another culture, people have a party. Look at what happens in New Orleans. If there's a funeral, there's a march, and there's a band and a jazz band, and everybody's playing. Why? Because they're celebrating life. So the importance here with the diagnoses is that we have to consider culture. I worked with a teenager years and years ago. They came from a family where there was a strong belief in ancestors. And in that, they had a shrine in their home. They did believe that they could talk to their ancestors. So when I started to work with the teenager, at first, when they're telling me that, yeah, standard question oftentimes with clinicians is, so are there ever, you have to do a suicidality assessment. So we'll ask, do you ever have thoughts of harming yourself? And we'll also say, do you ever, hear voices in your head that aren't your own thoughts? And she said, yeah, yep, I do. And it was like, okay, tell me about that. And as we got into it, it's that she heard people talking to her in the home. Now, the clinician hat would be, I wonder if she's having auditory hallucinations. But as we talk more, and I also talked with the family, what it turned out is that the mother also talked to the ancestors. The grandparents used to talk to the ancestors. So it was actually part of their lifespan cultural experience, which means we don't diagnose it as a mental health disorder. So we have to consider, there's another part, lifespan comes into play here. In other words, if I said to you, I'm going to describe an individual, basically they don't like to take baths. Their room is a complete mess. All they do is play video games. They don't want to do their chores, and it becomes a fight every time you talk to them. They tend to have these mood swings, and they yell a lot, and they basically, you can't be around them because, oh my gosh, when's the last time you bathed? And if I said to you, all right, we're talking about a 15-year-old, you probably would say, yeah, that's a 15-year-old. Now, if I said, that's a 52-year-old, you go, whoa, that is something's not right there with that 52-year-old, right? So lifespan also is important. And this is the first time that this DSM has considered that we have to consider culture and where are you in the lifespan. And sometimes what might be considered a diagnosis based on where you fall in life is also different at another point in life. So not to get, we'll just sort of move through some of this. Mental illness, basically then, it's something that is assigned. It has to have clinical utility. It has to consider lifespan. It has to affect their life. meaning that we don't assign a diagnosis if it's not having an impact. It has to reflect some kind of dysfunction across domains. That's the other part of what a diagnosis is. And it also, we're starting to consider modern science in this. Notice the other DSMs really didn't start to do that. They actually, in the new DSM, also look at prevalence rates and where does it tend to show up more often based on an age and based on things that are happening for people. And this criterion of clinical significance, when a disturbance causes clinically significant distress or impairment, occupational, family, social, in these important areas of functioning, it provides a threshold of distress and acuity. In other words, how severe is it affecting you? And it helps the clinician then assign the diagnosis. And this is beautiful. It protects the threshold of normalcy. In other words, for the longest time, the diagnostic manuals were all about what's wrong and broken. And now they're introducing the concept that for us as hypnotherapists, that is like our core, that it doesn't mean that you're broken. In fact, when I think I shared with you that concept, when I work with people with trauma, it's not that they're broken, they're injured. The reason is because if you're injured, you can heal. And so normalcy, wow, how cool, they're finally incorporating it. Lifespan, culture, all come into play. And how different behaviors and symptoms at one point can also, according to another point, may look different. You wouldn't necessarily assign a diagnosis. I'll give you another example. Suppose you're dealing with someone who's in their 50s, 60s, 70s, 80s, and they lose a life partner. And they're just, which is reasonable, incredibly grief-stricken. And maybe they do stop eating and they aren't bathing. And this is like a month or two after the person has passed. That doesn't mean that they may receive a diagnosis of major depressive disorder. What it means is they may be dealing with such despair in having to reconstruct their life. And so it's, now, if we're looking at 2 years later, a year and a half later, or we're seeing that the signs are starting to affect that they've stopped nourishing themselves and now they're basically sleeping all the time, then might they have moved into requiring more? And when people come into us wanting to deal with some of these issues, and if we were to use hypnosis, it might be to help them see that they matter, to help them see that they can take care of themselves again, that we can help them to motivate to find things of interest, to help them to come to terms with the grief that they've had. We could make hypnosis to help capture memories that help them to then move forward, to see that they still can. I would say if people come in and they're not working with a clinician on some of these issues, it can be, have you talked with your primary care doctor about this? Some of what you're telling me. And the reason is because it would probably be helpful for them to know. And then or might you work, consider, have you worked with a grief counselor or somebody from hospice that might be a help to you around this? I've worked with some people on the grieving issues where it would be awesome if they could go to hospice and join a grief support group. But what happens if they come to you and they also have dealt with social anxiety? Meaning, it's never been easy for me to make friends. I really feel very anxious. Even before this person passed, yeah, I've always had difficulty getting out and being around other people. Okay, would you care to create more confidence that would help you so that you could reach out more and find it to be more comfortable? Yeah, that would be good. I don't think it can happen, but all right, well, we definitely can bring in the hypnosis to help create empowerment for you. And I could see that as a powerful segue a step toward helping them get to the next level of support. So you could deal with their anxiety and maybe the feelings they have, possible trauma in having difficulty being with other people. Sometimes people in relationships create these almost kind of like a cocoon of safety, and so they may not need to get out beyond their partner, and they lose their partner, and now they're confronted with having to do for themselves and connect again. That may have been an issue for them. Hypnosis could help with that, and it could open the door for them to then go and get more help through possibly getting more grief support help. And so these just talk about some of the different changes in the DSM. And so you could think of diagnoses as kernels of information. We've talked about unpacking these kernels. And so understanding that if someone comes and says, wow, I have major depression. I mean, a great question is, well, tell me about that. What do you know about it? Now, sometimes people will get defensive. Well, you don't know? And then it can be, well, I always like to, yeah, I'm familiar with it, but I always like to ask. And if you're not licensed, but you're certified, it could be, I'm not a licensed mental health clinician. However, I am familiar with these, and I do help people with these, making use of hypnosis, but I'd like to know what that experience is for you. That's a great way to segue to help them to hear, you want to get to know them. I don't want to get to know your diagnosis. I want to get to know you. And if you're dealing with that, I want to know what's that mean to you. And so it can be, so tell me more about, how do you experience this? And in what ways are you experiencing it? And so this helps us then to see, and it can be, which is your thinking, your memory, your cognition. Then we also have the social domain. How do you connect with other people and family? We have the biological domain, which can be, what is your body doing? Hypnosis can work with each of these domains. Psychological, helping to change the false beliefs, to change the internal thinking so that it becomes more productive, where we can eliminate and reduce some of the mythic thinking. The societal can be anxiety, dealing with relationship, trust, helping them to feel more comfortable, more confident. The biological, are you having sleeping problems with your depression? Do you ever find your heart is beating? The physical. Do you ever find your heart just beats really fast? Does that ever happen? And where you're having a hard time catching your breath? And yeah, well, we can make use of hypnosis on that domain. And so beyond the label box is what we've talked about before. You are not your diagnosis. It is just part of your experience, and it can be an important part of your experience. I would suggest to you that for some people, the diagnosis is so scary that they won't even look at it. And yet, for example, if you have diabetes, you can choose not to look at it, and what that means is you're living in denial. Now, if you help somebody to be able to see that you do have empowerment in what you can do with this every day, the only thing in life we really have control over is how do you choose to respond to something. That is it. And that's powerful, because we sometimes place our need for control out there. If they'll stop doing this, if they will only do that, as opposed to, how do I want to respond to this? I worked with a fellow who had cancer, and with cancer, you can move into a period where you're taking different either hormone medications that basically are suppressing certain hormones that can be associated with fueling cancerous cells. I worked with a fella who was on a medication called Luprin. What Luprin does, it wipes out testosterone. And the reason is because their cancer, they needed to kind of flatten their hormones so that the cancerous cells weren't being fed, and it actually could sustain them. But the consequence with that was they had trouble with muscle mass, they had difficulty, and if you have low testosterone for men, it can lead to depression, low energy. And so we made use of the hypnosis to help empower them to see that the illness was something they were dealing with, and where did they have control? Well, the individual could still do exercise, could still, they couldn't build up bulk anymore because the testosterone was affecting that, but they could still have a sense of, I can do something every day. And that could then get refed into, see, you have something you can do to help yourself continue to live a quality of life. The hypnosis helped because then it wasn't all lost. When we experience an internal difference between who we were and who we are, that creates, I call it grieving the healthy self. And hypnosis can help with that. So it's very hard to believe, so I'm going to have this for the rest of my life. And how long will my life be? But if we help people see they can have a better quality of life and find joy, find belonging, find interest, wow. Then we're really just getting all their cylinders working. And so if we respect the symptoms and the signals, that's what we're really talking about. We can explore and discover what their need is. Is it a need to create more belonging? Is it a need to create more purpose in their life? Is there a need to create more relief from the symptoms and how undermining they can be for different illnesses? Isn't it interesting? When I work with people with medical issues, and they've been used to a robust, healthier lifestyle, and now they're dealing with a medical issue, then what it can mean is, well, before I didn't even have to think about what I was going to do that day. And now I am so fatigued, so I have to plan it out. And what ends up happening is the individual ends up, what happens if they had 2 hours out of a whole day that were really good? And then I'll ask them the following week, so how did that day go for you? Well, it was only 2 hours. And it's kind of like if you had sunshine that came out and the rest of the day was rainy, but you had 2 hours of sunshine, enough to go walk and enjoy it. Some people like walking in the rain, but wouldn't that be nice if you could say, those 2 hours were bliss? It's interesting to me that we can move into all or none thinking. Hypnosis could help relax some of that, expand their consideration for find and create joy in the moments that you can you? And you don't even have to think about it. Embedded commands, beautiful ways to be able to help people by inserting the ways you want to help change their thinking. It's really a cognitive reframe through hypnotic language. And what Patty has talked about, I am bipolar to, I've been behaving this way. I am dealing with this. I have this. I am not this. Even pain, migraines, cancer, depression, I've been experiencing since. And so we're helping people to think differently. These are just some abbreviated examples where someone comes in, they could say, wow, I got major depression, I got anxiety, I got a histrionic personality disorder. And so might we then, with some of this, if it's depression, do we look at what comes with depression can be fatigue. In fact, a very strong signal of depression for most people is fatigue. Sleeping problems is a strong aspect of depression. And in fact, oftentimes people that are depressed, when they go see their primary care doctor, the first complaint is, I'm not sleeping well. And what do they get? They get a sleep aid or benzodiazepine like Xanax or something, as opposed to, might it be a help for you to see a hypnotherapist? And maybe and it's very likely they could help you with your sleeping. Interesting, you could market yourself to primary care doctors and say that you can help. Or what about marketing yourself to sleep physicians? It's amazing how many people have sleep apnea and are using CPAP machines. And you could use hypnosis to help them to adjust to the mask on their face. Because a lot of people can get claustrophobic putting the mask on. And a lot of people unconsciously, subconsciously, when they sleep, they take it out. So they wake up in the morning because of the sleep apnea. Really has to do, it can be either an obstruction in your throat, but it also can be to being overweight. And when you have sleep apnea, what happens is people are actually having interruptions in their breathing. And the snoring that can be heard, that sounds like a train going through, can actually be them stopping breathing. When they do counts of their blood oxygen, what they find is it's low. And the pressure that this puts on the heart is dangerous. So sleep apnea is not a, I know you see ads on the TV for, you know, putting straps on and so forth, but it's serious. And I also see a correlation with depression, with sleeping problems. So you could market yourself to sleep physicians saying that you can make use of hypnosis to help with sleep, to help for people that have sleep apnea and requiring CPAP machines, that you can help them to sleep more comfortably with the apparatus on in their nose or the mask on their face. Wow, I can't tell you the numbers right now, but they're huge with the number of people that are going for sleep studies nowadays. This is somebody dealing with a bipolar illness, also opioids. The opioid crisis has been huge. That's why there's a large movement. I know in the VA hospital, in the last couple of years, they've actually reformulated their pain protocol, and it is very difficult to get pain medication. I'll share this with you. I worked with a fella who had been worked as a fire person and had injured their knee, and as it turned out, ended up having to get on pain medication. Was going to have a knee replacement. And so I did a pain protocol with the hypnosis, and they literally stood up after the trance, bounced on their leg, which was like, be careful, and basically said, I said, what's happening? They said, I don't feel the pain in my knee. He actually walked out without his cane, went back to the physician that was prescribing. Their physician called my office and said, can we have more cards? The reason is, now I didn't promise them I would get them off the medication. But the issue here was that many physicians do not want to prescribe the pain protocols. So if you advertise yourself to pain physicians, to primary care physicians, to orthopedics, that explain that you could make use of hypnotherapy techniques that can help create more relief in dealing with physical discomfort associated with whatever they're dealing with. Wow, that would be huge. This is a person with MS, and with this one, this is kind of a redacted version of the woman that I worked with. And so being able to change pain signals, because with MS, there can be pain, there can be vision issues, there can be Sometimes people with MS can have strokes, and with that, it can affect vision. People that have lost or impaired vision in one eye, it creates what's called monocular vision. Binocular vision is when you're seeing out of both eyes. That's what we need to have depth perception. So without it, that means everything's kind of flat. So think of the times you need depth perception: walking downstairs, walking at night, driving at night. So with this individual, we worked on hypnosis. I couldn't bring her vision back, but to help build confidence so that they could be able to maneuver more confidently, to make use of railings and to make use of their cane or assistive device, so that we could do that to create more comfort in dealing with their symptoms. And of course, that idea, I go back to the meaning of the illness can also be worked with in hypnosis to help create relief from mythic thinking that is actually undermining them owning what they're dealing with in a way that is hopeful, as opposed to feels like a jail sentence. So what's the plan? The plan can be consider the diagnosis. In other words, when we deal with depression, consider those three domains. We have the psychological, so do they have negative thinking? Do they have, it's actually a fancy term, depressogenic thinking. The brain, when we're depressed, actually nature did a cruel thing. When we're depressed, the frontal cortex doesn't get the same level of blood flow. And so think of that, as we talked about before, executive function. It's like the conductor of the orchestra. So the frontal cortex actually, when they do PET scan photography that shows how the brain lights up with blood flow and metabolic activity, the frontal cortex dims like a dimmer switch. The limbic system and the amygdala, which is that part of our brain that's charged, the reptilian brain, the part of our brain that's just gets energized, like with trauma. And then what happens is that people are not able to think their way out of a depression. Concentration gets affected, memory gets affected. So if someone comes in and says, yeah, I deal with major depression, then might you deal with, and a question can be, you know, I'm familiar that when people are depressed, sometimes they may, it may be difficult to think positively. Sometimes thinking more negatively may be a part of that. Is that anything you deal with? Oh yeah, yep. It's really, I think the worst. And okay, might we use some hypnosis then to help empower some positive thinking for you? What about the memory stuff? Could it be, are you noticing it's harder to remember things? You said you deal with depression. How's your memory with all that? How's your sleeping with all this? Again, how's your eating? If we find those three domains, psychological, societal, social, and the biological, hypnosis can target any of those elements in there. Anxiety. Well, people can experience anxiety in our thinking. That's called worry. We can do it in how we feel. I just feel anxious. It can be in our body. What are the signals? How do you know when you're anxious? How does your body tell you? Well, it feels like an elephant sitting on my chest. Well, that doesn't sound good. It sounds like it doesn't feel good. No, it doesn't. Well, what would happen if we could make that elephant lighter? Would it be wonderful if it felt like a feather? Oh my gosh, you could make that elephant feel like a feather? You have the power to be able to change how you experience, and we can make this happen with hypnosis. Whoa, what a beautiful reframe. Can you hear how you can take some of those things to take a component of the diagnosis that you did not diagnose, but you just inquired, and use hypnosis? It becomes a hypnotic target. And of course, we talked about panic attacks and we talked about phobias. Boom. That's like very ripe terrain for us with hypnosis. We could make use of timelines if we want to get to initial sensitizing events, regression. We can make use of those. Unpacking the diagnostic code is really asking the questions in those three domains: the psychological, the societal and the biological, to see what is their experience about. Teach me what this is like for you. How would you like it to be different? And sometimes people don't know. Sometimes, I don't know. I just don't want to have it. Okay, well, would it be all right if we explored a little bit about this so you help me understand what your experience is? That will better help me to help you using the hypnosis. Great, okay. And then we can also target the hypnotherapy outcomes based on this interviewing, this conversation we just had, that came about from understanding that the diagnoses are like suitcases, and I want to understand the meaning you have. I want to understand how you experience it. How does it affect those 3 domains? And where can I bring hypnosis in that can create relief, reduce the signal, help your functionality, improve your confidence, and help you to feel you can improve the quality of your life, living with what you're living with. And these are just some other tips. Consider the comfort level. Consider your comfort and prowess with the technique you're going to use. Incorporate the value of the clinical power of the technique. So in other words, is the technique I'm using advisable for this? Could I make use of it? And with the training that we're talking about, we've identified different types of hypnotic targets that we could apply any of these different approaches. Now, I will tell you, not every approach works with every person. So you may use an approach and find, you know, it just didn't do it. Okay, let's go to a different approach. And these are some of the different things that we might do with medical issues: panic disorder, agoraphobia, which is fear of leaving the house. It's also fear of large spaces. And I will tell you, I see a correlation between panic disorder and agoraphobia, where people will start to avoid, like, going to the supermarket, you know, or not just bridges. Pain reduction, create sensation relief, habit control. Well, people with depression and anxiety might also be dealing with smoking cigarettes. Addiction issues, trauma, we talked about that last week, fears and phobias. And then also what psychogenic has to do with, in the psychological domain, different things that can affect us: grieving, poor esteem, confidence building, building interpersonal confidence. See how we brought that up with the grieving person, and the fact that if they dealt with issues related to comfort socially, that now they're going to be impeded with being able to join a grief support group because the social anxiety that maybe they have had is starting to kick up. You don't have to label it, but it could be that dialogue of, has it ever been hard for you to make friends and get out? Or would you say you had a large circle of friends, or just the right number? And again, if you start to find out, you know, I've never been a big friend person. Actually, my partner was my best friend. Oh, how nice. That must be so hard not having them. And at the same time, I can't help but wonder if there was opportunity to create more healing for you through some different venues that involve meeting people, might that be hard then? Yeah, I can't imagine doing that. Imagine someone going into a nursing home and they had some of these issues. Well, that means that they're going into the nursing home carrying their anxiety, which means they're going to have difficulty connecting with people. They're going to be isolated in the nursing home. And there's nothing worse than being isolated when you have people around. So might you make use of some of these techniques to be able to help somebody dealing with a transition in their life? And that brings us to a close on how we can make use of an understanding of diagnoses with the hypnotherapy techniques that we have. Any questions?
No questions from me, but it was just, that was a really helpful presentation. That was great. Really
well,
awesome.
thank you.
Yeah.
Thanks, Eric. I really love it. Very precise and concise.
Oh, well, thank you.
Thank you.
Thank you.
Eric. It was great.
Unfortunately, my girlfriend fell in love with you.
Uh-oh, Eric, you're in trouble.
Uh-oh.
It's very hypnotic. I just go into trance when Eric starts talking. I don't know about the rest of you, but
I feel the same way. It's a very soothing voice, Eric.
Oh, well, thank you.
That was very good. Yeah, absolutely.
Oh.
But when someone comes to you and say it's, I don't know, something like, you know, I've never had anyone come to me who had a really serious diagnosis, I mean, like more than one thing. So they're diabetic, and they have cancer, where it's just, you know, the first thing I'd be thinking as a hypnotherapist is like, where do I start? You know, do you have like, when it's someone that you could go in so many directions, do you have like a go-to, I mean, other than asking them, okay, how do you experience things and getting all that information, but is there something that you usually, I don't know,
In other words, kind of like a blueprint. Where do you go if they come in with these things?
Yeah, because I mean, you know, there are basics that we know how, that you guys have taught us. That's great. You know, you get the information, you see how they experience it, you know, all this stuff, and of course the relaxation bit. But is there, I don't know, something that,
Well, I probably, what I can do is I'll send something over to Patty. When I've been talking today about, if you think of three systems that we're always living in and helping people in, which would be the psychological area, the societal area, and the biological area. And is it possible then, like someone comes in with diabetes? So if I'm thinking psychologically, I'm thinking, well, how do they think about this? What are their thoughts about it? What does it mean for them having diabetes? What is the worst part of living with diabetes? So psychologically, they're going to tell you. But in that telling, some of that might go to the social thing. You know, I'm so fatigued that I just can't run with my grandchildren anymore. Okay, and actually I have to admit that maybe it also affects having sex because of the diabetes. So, okay, so intimacy is hard. Yeah, but you know, I'm not sleeping as well because sometimes I wake up with low blood sugar and stuff. Boom, now you've got those three areas that are almost like a map. And then we put on our hypnotherapy hat and we go, what can I do with what they've told me in how they think about this? Is it a need for empowerment? Is it a need for hope? That with diabetes, might it be that they just love potatoes and they love their bread? And it's like, well, that's big time carbohydrates. And so the question is, how can they think differently in a way that can help them to eat healthier? You know, one of the classes that I've been in with Patty, and there was a nutritionist in the class, and we did an exercise together, and I'll never forget this. It still works for me. And what the nutritionist said was, while I was in trance, and I remember it, it was like it got punctuated indelibly in my mind. And if I need to re-strengthen that embedded command, I can do it, and I can use self-hypnosis. But what the nutritionalist hypnotherapist said when I was in trance, and what we were working on as a well-formed outcome, was that I wanted to lose some weight and I wanted to walk more. And so, because she was a nutritionist, she said, well, and here I am in a very, very deep trance, and it was like, and might you notice how wonderful the colors on your plate can look so delicious. Now, what has color on a plate?
the veg.
Yes, the veggies. I tell you, I still remember the veggies. So now, oh my gosh, I love that color on the plate. And so, and she didn't have to say, and you will eat every vegetable. It wasn't a direct suggestion. And it was beautiful because it really captured something else. And behind that, now I love vegetables. Now I like vegetables. Now I love vegetables. So, but so it can be, do we think along these three domains, and we ask the questions, and then we look for where can the hypnotherapy create a change in thinking, either to be more positive, to enjoy something that is healthier. I mean, here's another one. Exercise, being able to have regular exercise during the week. And it doesn't have to be, you know, pounding out weights unless someone really wants to do that, but it could be taking that walk and being able to help to create motivation and incentive and then self-acknowledgement. Wow, hypnosis is awesome. Now, you could even throw in some other little perks, like you could say, and might you notice, as you take that lovely walk this week, that whenever you see the color green, might you feel even more motivated to enjoy that walk the next time? Well, now, if they were in the desert, the color brown. But if, you know, if it's going to be green, or if it's in the city, and might you notice all the different windows that just allow the sun to come in as you take that glorious walk. Boom, what you're doing is creating a sign symbol association hypnotically between what they're experiencing and what do you want them to have as a well-formed outcome, which is building motivation but enjoying it. So
Yeah.
So I would say, think in terms of personal habits that can help with medical issues. What is self-care? What would it look like to you? I mean, you could ask them this question. You could do it without asking them, but I think we strengthen our well-formed outcomes by knowing what it is. And it doesn't mean a direct suggestion, like with the vegetables. It could be something that makes it inviting, attractive, more enjoyable each time that you do this. And isn't it interesting when we do hypnosis, you know, we may do as we're bringing someone out of trance. And might you notice that time after time, the more that you experience this, the easier you go into hypnosis. So again, we're really using the same future pacing technique, but we can do it to help change self-care. So I could ask them, how do you take care of yourself living with this? Are there any places where your self-care could be strengthened? Are there some things that are hard for you to do? What's easy? And then now, and I'm taking notes, and think of it as a template: psychological, societal, social, and biology. And now you can create your hypnosis plan based on what they're telling you. So think of self-care, think of comfort, think of, are you seeing places where there's something in their thinking and their behavior that is getting in the way of them better taking care of themselves?
That's super helpful. Thank you so much.
Great.
And, you know, I love the way, one thing that I even changed and I translated it to for my Norwegian clients is, I love the way you use, and might you consider. I've never done this, but and might you, for some reason, those two words, and might you, because it's so like, you know, it's hands off, but just in a very sort of innocuous, inviting way that no one's going to take exception to, or, you know, I just, for me, I just love that. So that tone, and might you, that's great. Thank you. Thank you so much.
Well,
it is so British.
Yeah.
Really?
It's very respectfully permissive.
Yeah.
Yes, absolutely.
Yeah.
Eric, would you describe that pattern of language as Ericksonian?
Yeah, I like to think of it that way. It's I'm basically inviting them into their own experience, as opposed to I'm going to tell you what your experience is. Because again, for many people, the telling you just can hit the wall of discovering there's a part of this I can't do or I don't know. And, you know, there's a term in hypnosis, we call it the hidden observer. And what that means is when people are in a hypnotic state, we have consciousness to be able to do metacognition. That's the ability to think about what we're thinking about, even in hypnosis. So the more direct we are, though we can make use of that as a technique, I think there's a greater likelihood of hitting that wall where the hidden observer has that rational thought, I can't do that. But you raise it as a might or perhaps, and wouldn't it be wonderful? Like opening up a present to discover that you can feel marvelous.
Yeah, I like that one too. And wouldn't it be wonderful? I wonder if.
And I like that because it's a question
Yeah.
method, and from what I've learned, the brain is a question answering machine. And if you're constantly asking questions, the subconscious mind has nothing left to do but to find an answer or a solution.
Right.
Might you?
And it's interesting, one of the language patterns is where you question it after you said it, like, and with each comforting breath, can you feel, or you can feel better and better, can you? It's like you ask that kind of, really? Yeah.
Okay, cool.
Okay, well, it was a pleasure talking with you all today.
Thank you so much. Really.
Thank
Great,
you.
Eric.
Thanks a lot.
Enjoyed
Appreciate
it.
Thank
We
you.
appreciate it.
So helpful.
Oh, well, thank you.
Are we done with you now? You're leaving
Yeah,
us?
I think so.
Thank you. I think we got a good
Have a
recording.
nice
this
day,
time.
Eric.
It was great seeing y'all, and happy Father's Day to any of you that
Oh, that's
have that
right.
going on.
Yeah.
Happy Father's Day.
Thanks.
Happy Father's Day. Yeah.
Take care now.
Eric.
Talk
Thanks,
to you
Eric.
later.
Take care.
Bye.
Cool. Very cool. That was a great segment. I think
Yeah.
that was the best one yet for the DSM, because that can be kind of dry stuff, but he makes it fun. He makes it interesting.
Yes, yes, wonderful.
Adding all the different things. You all, I guess I just always assume, since you're all working in the field and you've all been around and I watch the head nods as things are happening, that you all are familiar with conversational hypnosis, Ericksonian permissive language, that kind of thing. To me, that is the most powerful, in my opinion. And that's why metaphors work so well with health issues, isn't it? Because it's inference. It's not demanding or commanding or intruding by the hypnotist. It's offering possibilities. You know, I love that word. It's part of my company name, you know. And if you open up, when someone's in hypnosis, when you introduce a possibility with might you, I love it. Yeah, that's, I always think of that as a Ericism, you know, he's, might you notice, you know. But when you hear words like you may, might, wouldn't it be interesting? You know, those kinds of words, they're inviting, like you said, that question of isn't it nice to know? You know, those kinds of things. They're just so non-invasive that when someone's in even a light state of hypnosis, it allows their unconscious mind to start scanning for those possibilities that are relevant for them without us feeling like we got to tell them. You know, I had a recent client just this past week, just what, Alexandra, just what you were saying, I was thinking of her when you were asking your question, because she came in with the laundry list. And oh my goodness, and I'm listening on the phone to her, and then when she got in the room, it was even more. And I tend to, you know, depending on the personality of the person, I like to interrupt patterns. I like to start doing that in the first pre-talk, because I want to start using those as opportunities to bring to their attention certain things they're saying. And like I said, depending on their personality will determine how abrupt or how softly I introduce that idea, because I don't want to, you know, make them feel like I'm interrupting them for the wrong reason, but to allow them to start to notice. And it really, with her, I had to start really interrupting because she kept going off on all these different things. And it can be, you know, kind of challenging to find out, where do we start with this person? And it seemed obvious at the beginning, but as the more she talked, the more it got not quite so obvious. And I didn't want to determine it. And that's where we use our sensory acuity and questioning and listening skills. And again, I'm always working to improve on all of those things, because what it ended up being in my mind, that I knew I seemed to be the resurfacing issue with her that I don't even think she was aware of. And I didn't determine that she was ready to become aware of quite yet, because it was something that was resurfacing that was showing me, though, that there's this other element going on within all of the things she was telling me. And that's where we use those skills, because hypnosis, as we know, the starting point for a hypnosis session is to really get focused in on one thing. You know, that's the key to start the session, is to get more focused, you know, and to zero in on, here's the starting point for where we're going. That's why we get a well-formed outcome for that first session. Doesn't mean you can't, you know, and then there's the ripple effect, of course, because in order for them to change to affect that one thing, and I'm always listening for what is the most prominent thing, the recurring emotional issue, and it comes from, again, through their language they're using, and through what you're watching in emotional shifts as they're talking. So to me, it's listening and watching for what is that thing. And I don't know how you really teach exactly how to look for that, other than just being aware and asking a lot of questions. And like I said, I think of it as the thing that kept recurring. There was a theme that kept recurring to me, that I kept seeing coloring every single issue she talked about. And the thing that was the presenting issue that looked like it was going to be coming in, which was a pain issue, ended up actually being more of a sideline. You know, and it's just, you know, it's like with weight, it's not about the food. With smoking, it's not about the cigarette. With pain, it's about usually an underlying emotional or some other things that are going on that, you know, and again, we want to find out. So it ended up in the first session being more of I actually did a timeline technique with her, which is something I like to do in the first session. I did a long progressive relaxation, because she was so tied up in knots over all these things. And for a couple of years had been trying to figure out what was going on with these problems she had, to the point where her entire day is like, and at night when she's sleeping, is consumed with this thing that's going on, and trying to figure out how to deal with it. And again, we know whatever we focus on amplifies. So to me, the first session for her was more about, how can I get her to intentionally, a few times a day at least, have her mind focus on something else, instead of being totally consumed with this thing. I mean, she was seeing every kind of therapist, every kind of alternative medicine, and just researching, and even had her, you know, her spouse researching, and it was just a constant thing. So to me, it was more about being overwhelmed with the fear that was coming out. Was really the issue I kept seeing, was the fear of not knowing what it was or what she could do about it, because nobody was giving her the answers that she felt like were adequate for her.
So when you did the timeline, Patty, did you go back to like way back to before? Like,
I always go way back.
Like go way back, and then just.
I go back. Well, you guys got the timeline basic thing, and when I talked about it, and I don't remember, I think, in the script that I sent you, I'm sure I do it in there. To me, my goal is to get all of those positions covered, you know, looking at it from right after it's done and you're okay again. If it's a trauma, you're assuming there was an event that started this sequence, even if they're not sure what it was. I'm assuming there's something that started this. They weren't born with it, in other words. And in her case, definitely, it's only been a couple of years. But for anybody to go back and look at it from after that event's done, from the unconscious level, and you're okay again. In other words, you survived it, whatever it was. and then to notice it from right over the top of it, and then to get that other perceptual position of before anything ever happened having to do with it. So, and that's a powerful place, because that's a place of safety and nothing's even happened yet. So you can get a different perspective of free from the emotional, the idea is free from the emotional impact or connection from that, again, that higher position, perceptual position, which again can represent for some people higher mind, meaning I'm more in touch with my spiritual self, or whatever their thoughts are about those kind of things. It's got all kinds of implications with that too. And then I always take them back to the point where their human life started. I started doing this a few years ago, and it just became part of every single time I do that in a, if it's in a first session many times, or at least some variation of this, because it's going to be a point where I can take them to have their unconscious mind remember this is when you were just pure possibilities with all of the things you were born, that were inborn, traits and characteristics and those wonderful things and talents and potentials and all of that. But nothing's happened yet in the human life. So I like to take them above that moment to have their unconscious mind become aware of when they were pure, no human experiences yet, when they're just pure possibilities. To me, that's a power position. And I like to anchor that in. And then sometimes I even take them farther back, which depending on the person, I'll take them farther back and even up higher so that they can see there. And this comes from, again, a lot of the Tad James work does these kind of things, where you're looking out way down there and out in the future to where your entire lifeline from when you were first, came into human form to that moment of now, way out there in the future, that it looks like it's about 2 inches long. You're that high and that far back that it's that, and it gives a different feeling for it. That life, that whole life that you've lived so far is down there, and everything that ever happened. And then I bring them back to that moment when that life started again, and go, now you realize all the possibilities are here. You have all the, what you came into the world with, and each experience is a learning opportunity, where you're developing skills and experience that make each subsequent experience be something that you bring more resources to. So then having them pick up all the resources, some of which, and strengths, and, with the implication that their unconscious is now remembering all of those things they learned. And if there was something that they went through that they missed a lesson, or missed the opportunity to realize they got stronger, or gathered some kind of a resource from, to have their unconscious, assuming that the unconscious knows to pick up those missed lessons. Does that make sense? And then
Have you
coming back.
ever had somebody say, I don't remember, I just don't, and then they're not really ready to work? I mean, you
Don't
just
remember, you talk about like in a
can't go back.
pre-talk, or?
They don't want to go back. They just, I don't know. And you go back and they come up blank.
You mean like after the session's over, they say that?
No, like during the session, when, and you're doing the timeline technique.
Yeah, I don't usually have them talking on timeline.
Oh, that's right. Yeah. Okay. No, I wondered if
and
somebody
even if they
you.
did, yeah, because there's some basic comments even in parts therapy, because it's done much lighter with verbal interaction, as you'll see. I hope we have time to do it today. Ooh, we are running out of time, aren't we? So I'm always assuming their unconscious is with me, and there's things you can say, like, even if you aren't aware of what the learnings or the new discoveries you're making are being brought into the unconscious part of your mind. Anything that's going to assist you out there at now moving forward is automatically being drawn back in, because your unconscious knows what you need and knows if anything was missed that will help you now moving forward, now can be retrieved from that history. Because the assumption is that something either needs to be adjusted or looked at from a different angle, or a lesson was missed, or they didn't realize, if that hadn't happened, because there's questions you can ask in the waking state too, to reinforce all these things or to prepare them to do the timeline. Like if they know they had a trauma, let's say, you can say, well, if that hadn't happened to you, what would you not have today? What would you not have if that hadn't happened? You know, you can get them to start realizing, oh, well, you know, because that happened, I became much more independent, or I became, you know, they can start to think of it in ways of that actually gave me something positive, you know, instead of thinking it as a victim, in other words, because that's our job, is to get them from thinking that that thing victimized them to thinking that, you know, I actually have the power to turn that into something, or to realize that's something that made me who I am today and actually gave me some resources. Or sometimes the only thing they got was, now I realize and I know to never put myself in that position again, you know, in that situation again, if it's something like that. So there's, you know, there's, I'm sorry.
May I add something?
Absolutely.
To Alexandra. When I see that the client is not ready, or the client says that she is not ready, then I build into the deepener that you will remember only what is safe to you to remember.
Yeah.
And that makes it easier for them. So then they can go back and they can remember, because they know they won't remember consciously after that. So it makes it safer for them.
That's good. Yeah. Yeah. If they bring that up in the pre-talk, that'd be a great thing to say, because then they feel safer, because you got to make them feel safe. That's part of the pre-talk, is gaining rapport. They have to feel comfortable and safe with you.